with your exam for these patients, is it a different exam, or is it the same exam that you do for any patient coming in?
For me, it's the same.
Yeah, same for me, Ashley. We learned a lot in the days when a company called Spyrox was commercializing the Latera implant. And I've continued that now that Aerin Medical has the Vivair treatment for nasal valve collapse. We were taught as residents that nasal valve collapse wasn't that common, like a single digit or teen percentage of patients. But I think that bias was because we didn't really have a lot to offer patients outside of functional rhinoplasty. And so a lot of patients just didn't have access to that procedure, so we didn't look. And with Spyrox first and Aerin soon afterwards, it really raised at least my awareness, and I think a lot of our colleagues, first of all, to examine the nasal valve and look for static collapse. Of course, that's usually obvious, but dynamic nasal valve collapse. And we realized, there's a heck of a lot more patients that have this than we thought. So that has become now an extensive nasal exam, but including looking at the nasal valve dynamically has become a part of every exam.
And when you're looking inside the nose, do you medicate with Afrin? Do you look first and see what it looks like before, and then you spray so you can look a little deeper, or does it matter?
I usually don't medicate them, just to use a speculum and a headlight. Usually by the time I'm scoping somebody, my staff is already in this, sprayed in some oxymetazoline and some lidocaine. So they are decongested unless I specifically say no. But again, that's more important when you're looking at the turbinates and even the swell bodies. I think you can still identify and do a modified caudal, whether they've had Afrin or not, and still get a good idea if that might help them treating the nasal valve.
Yeah, I do the modified caudal. I'm probably the outlier. I don't spray anybody's nose unless I'm doing a procedure on them. So unless I'm like doing a debridement after sinus surgery or a nasal procedure on somebody, I don't spray anybody. When I do flexible and nasal endoscopy, I do rigid nasal endoscopy. I just try to be gentle. Yeah. I had I had an experience one time where this old lady got I didn't know anything was wrong. I sprayed her nose and then I scoped her and everything was fine. And then I got a handwritten letter in the mail 2 days later that she had got coronary vasospasm from the Afrin and ended up in the cath lab, and they told her it was from the Afrin, and she wrote me this letter that she wouldn't be coming back. So I called her and everything was fine, but yeah, I don't spray anybody.
Yeah, now nobody gets Afrin.
Yeah, she ruined it for
she
all
ruined
of you.
it for everybody.
Yeah, if they ask for it, I tell them more people complain about the spray than they complain about the scope, and if they're like, no, you better spray me, then I spray them. So.
And are you doing a flexible, I would assume you're evaluating the entire upper airway. So you're looking in the nose, and then you're going to kind of go back and look at the palate and pharynx and, base of tongue and kind of the whole airway.
I try to do a flexible endoscopic exam that incorporates nasal endoscopy and flexible laryngoscopy on all my new OSA patients. I try to do it on all new patients just because I feel as an ENT, that's something that nobody else can look at.
Yeah.
And we're at the end of the road and you're on the hook for that. So try not to miss anything with that stuff. But I do it. I think that your oropharyngeal exam is probably best accomplished with a headlight and a tongue depressor. But I do really value looking at the nasopharynx and the velum and the posterior nasal cavity with a flexible or rigid scope.